Okay, so with that, I'm going to hand over the floor to Jessica and we will get started. Thank you all so much.
Good morning, everybody. It's 6 a.m. here in Phoenix, and so it's nice, bright and early. Not really, it's super dark out, but it's a pleasure to be speaking to all of you on a subject that's very near and dear to my heart. So we'll get started here on head and neck cancer and the speech language pathologist role. Give me 1 second while I just get my bearings. Okay. Very honored to be speaking for Brooke and Tim's Medical University. It's exciting. So here are my disclosures. And just a little bit about me. So I hail from Chicagoland. I went to University of Illinois, and then I went to Rush. And I was really fortunate to have a head and neck cancer course all into itself. But just to give you some historical perspective, I did not learn about, for example, external and internal lymphedema in my coursework, and neither did Brooke, and I'm sure neither, maybe some of you, if you're in school right now. I'm hoping that the wheels have kind of changed. So that is, I'll bring up some kind of things that have evolved over my 15 years of working with the head and neck cancer population. So I was at the VA Medical Center for my clinical fellowship, which was incredible. And then I started a head and neck cancer pathway with the cancer team at the VA. I mean, I remember pitching the idea of why speech pathologists should be working with our cancer patients to our radiation oncologist at the VA. And I was young and nervous, but it did pan out, and I was able to work with our nurse navigator and start getting consults fed to us. And then things got a lot easier when I went to work at Cleveland Clinic in Florida, because there was already like a pseudo-established pathway. There were things that were basic, but I needed to kind of fluff up and add. But I sat on tumor board. It was very exciting, and the collaboration was great. But then it got even better, and now I'm at Mayo Clinic in Arizona, and I work with a great head and neck cancer team. I'm in the Department of ENT, and we work very closely with our radiation oncology group. And so, if you have questions about collaboration or starting something or improving a pathway, that's what this presentation is for. Other couple things, I'm board certified in swallowing and swallowing disorders. That is a very important certification for me. And I also established the first multidisciplinary swallow clinic at Mayo Clinic. And it's great. It's like a one-stop shop. So I partner with my GI and my ENT, and patients come from far away, and they come in, they get a fluoro study with me, and I sit down with the docs and I go through that fluoro and I talk about what I think is going on, and they have an idea. All three of us go into the room and we scope the patient. So we do laryngoscopy, and then we go down and do a transnasal esophagoscopy. And then the GI doctor sits and does his little one-on-one, and then we all come up with a plan. And it's been incredible. It's been a game changer. And so we're going to put a couple papers together on that, and that'll be coming soon. Anyway, let's get going. And if you are not following on the Swallow Nerd on Instagram, I would love to have you follow along, and I just post interesting cases. And I think it's fun for fellow nerds who love dysphagia and all the things. All right, so learning objectives. We're going to describe the head and neck cancer patient, the evaluation and treatment considerations and care pathways out there. We're going to identify the speech pathologist's role in diagnostics, prevention, and optimization of lymphatics, jaw opening, and swallowing. And we're going to list ways that TIMS MVP can be useful for the head and neck cancer population. I do wish TIMS existed long time ago when I started working, but now it's here, and it's really been incredible to use daily, and not just for head and neck cancer patients, but it's great. Okay, so we're going to get going with this. I made this little word cloud, and you can see some very important words within. And so we'll start with some stats. This year, the American Cancer Society estimates that in the US, approximately 3 to 5% of all cancer will be in the head and neck region, and an estimated 54,000 Americans will develop head and neck cancer, and nearly 11,000 deaths will occur because of that cancer. And cancer treatment cause a myriad of toxicities for head and neck cancer survivors that significantly burden their health and quality of life. So it's not surprising that impaired swallowing out of all of these was the highest cited reason for decisional regret in 972 head and neck cancer survivors 6 years disease-free. And lymphedema awareness and earliest identification and intervention is a hot topic right now. You're going to see it a lot at ASHA. It's been at ASHA. It's going to be a lot of state ASHAs. And so, because if left untreated, it will result in fibrosis, which is a major precipitating and exacerbating factor for many of the impairments you see here, particularly swallowing. And lymphedema doesn't just happen from radiation. It can also happen from surgery. So we'll talk a little bit more about that later. Swallowing impairment can occur from the tumor itself impacting the biomechanics, which occurs in up to 40%. And the example here would be this patient with this very large hypopharyngeal tumor. This is the patient's baseline. This is what the tumor has caused. This patient walked into an outpatient swallow study at the VA, and I was wondering how he was keeping himself alive. And he told me soup. But I kindly walked him to the emergency room after watching this study in horror. I don't know how he was doing, but this patient would not fare well during treatment, especially radiation, without enteric support, which is why a baseline study is so important. And we will need to track that function over time because those with baseline impairments are at a higher risk for worsening function during and after. In fact, if you have a baseline dysfunction, 70% will have a chronic swallowing impairment following radiation. But generally speaking, we see mostly swallowing impairments from cancer treatment, surgery, and radiation. So this is the same patient 6 weeks following radiation, now with treatment-induced lymphedema and still demonstrating poor pharyngeal clearance with persistent airway invasion. And obviously that tumor where it initially invaded did some damage. There's a lot of factors going on there, but that's just an example of the problems we see. So various aspects of surgery and radiation are listed here, and they matter because they will impact sensory, motor, structural, and mechanical aspects of function in different ways. And as you know, the health ramifications of swallowing impairment are serious. The efficiency impairment can lead to unintentional weight loss and nutritional compromise, and the safety impairment can lead to respiratory distress and pulmonary infections, and both can lead to death. The NCCN practice guidelines support the involvement of a speech pathologist to minimize treatment complications and promote health outcome, particularly in swallowing, breathing, and communication. An interdisciplinary model is necessary for the highest level of care of our head and neck cancer patients, and it must include specialties beyond oncology, radiation oncology, and head and neck surgery. Speech pathologists' functional baseline measures are strong predictors of long-term abilities and dysfunction, and ideally should inform treatment decisions made at tumor board. So for example, a patient's swallow may be so impaired from tumor burden that a therapeutic PEG is indicated prior to definitive chemoradiation, and that would be something the speech pathologist should be bringing to the attention of the team. And another example is that a patient's swallow or their voice and breathing is so deteriorated that a total laryngectomy is preferred over re-irradiation for cancer recurrence. So here are the most common patient scenarios a healthcare provider can encounter with a head and neck cancer patient. The patient had a resection only, with or without reconstruction, but there's no indication for adjuvant treatment. The patient had a resection and has an indication for adjuvant treatment, so chemoradiation after. The patient has a functionally unresectable tumor and other reasons why they would only require definitive chemoradiation, no surgery. The patient has a history of radiation but now needs surgery for osteoradionecrosis or recurrence or recurrence, and then or they need radiation for recurrence. And then finally, the patient is a late effects radiation case. Each of these scenarios have different evaluation and treatment considerations. For example, the vast majority of my late effects radiation patients have severe pharyngeal swallowing impairments. They routinely aspirate, and they have for quite some time, And my goal with the evaluation is to see their current function, optimize what I can, see them yearly to monitor weight and pulmonary status. And sometimes their functions do deteriorate, and oftentimes do, because radiation sclerosis is progressive, and a functional laryngectomy is indicated for improved quality of life. And just a side note here, chronic aspiration in head and neck cancer population is different than chronic aspiration in patients with neurologic impairments. These patients can typically handle it better than the neuro population, and making them NPO because you see chronic aspiration is detrimental to their residual function, because the subsequent disuse atrophy seemingly speeds the fibrosis process. They get stiffer faster. You're taking away the one thing that is keeping them at that level of function, even if it's super poor, and it's very hard to get that function back. Okay, when working with head and neck cancer patients, these are the body systems that I always keep in mind: breathing, speech, swallow, jaw, and lymphatics. And I think it would be a very good idea for us to start thinking this way as we go through the pathway and keeping these in mind. So I'll have them on the side of the screen so that we can have them as reminders. But speech pathologists are well-versed in breathing, swallowing, and communication. Further, in working with the head and neck cancer population, we should have a solid understanding of how resection, reconstruction, and radiation negatively impact speech and swallow structure and function. But it's safe to say that the jaw and lymphatic systems are not something that we learn in graduate school, as I mentioned before. So let's just touch base on these really quickly. So this image is courtesy of Cranial Rehab. I love that company. The temporomandibular joint is a synovial, condylar, and hinge type joint that's between the condylar head of the mandible and the mandibular fossa of the temporal bone. It's composed of numerous ligaments and muscles that permit a variety of complex movements necessary for life. Everything listed on the screen there: biting, chewing, eating, just to name a few. Typical opening for males is 50 to 60 millimeters and 45 to 55 millimeters for females. We have a highly intricate and loaded closed system of lymph channels, vessels, and nodes through which 1 to 2 liters a day of lymph flows, carrying protein-rich fluid from our tissue spaces back to the bloodstream and eventually the heart. Of the 450 lymph nodes of the human body, 60 to 70 reside in the head and neck, and they're arranged in both vertical and horizontal rings, superficially and deep, and they play a critical role in our immunity and homeostasis. The lymphatic system is easily disrupted in patient populations outside of head and neck cancer, such as patients with any non-cancer surgical procedure to the head, neck, and chest, such as an ACDF, for example, and the same interventions certainly could come in handy for these individuals, so keep that in mind. Okay, now let's discuss some basic evaluation considerations when looking at these body systems. So breathing, a couple little things. The tumor or cancer treatment can negatively impact breathing. So what's the patient's breathing situation? Is this their baseline? Are they fine on room air? Are they stridorous? Do they have a tracheostomy because of lymphedema from the cancer itself or from the treatment narrowing their airway when this is at the time that you're receiving the patient? Do they have a stoma? Are they a laryngectomy patient? Now, speech. The tumor or cancer treatment can negatively impact speech intelligibility. Performing a motor speech evaluation as part of this workup. We know the 5 subsystems of speech: respiratory, phonatory, resonatory, articulatory, and prosody. How intelligible are they at the single word and connected speech level? With swallowing, the tumor or cancer treatment can negatively impact swallowing safety and efficiency. So both a clinical and instrumental assessment of swallowing is critical. MASA is the man assessment of swallowing ability. MASA quantifies the clinical swallowing evaluation. So it's what you do for a clinical swallowing evaluation. You're putting numbers to it. It evaluates 24 skills pertaining to oral, motor, and sensory components of swallowing. And performance for each skill is measured using a 5 or 10-point rating scale, and it's tallied to create a composite total numeric score out of 200 points. And then it allows for you to have an aspiration risk score and a dysphagia risk score. And it's defined as either no abnormality, mild risk, moderate risk, or severe risk. And it was initially validated on stroke patients, but it has been found to have good sensitivity in non-stroke patients, such as those with head and neck cancer, cardiopulmonary disease, connective tissue disease, neurodegenerative disease, and elderly patients with pneumonia. And so I talk about this because we should be using something standardized when we're doing a clinical swallowing evaluation. The MASA is an excellent tool, and it is available in an app. And so I was using that inpatient when I worked at Cleveland Clinic, and I very much enjoyed it. I don't do inpatient anymore, but I still use it. And, excuse me, I want to bring your attention to that there's a MASA-C, which is a modified version for cancer patients. And it is published, but Dr. Carnaby has yet to publish a manual, but it is coming. So stay tuned on that. Digest. Okay, so let's move on to instrumentals. You've got your clinical, and then you need an instrumental. And so fluoroscopy and endoscopy are essentials in the head and neck cancer population, and I would argue in all of dysphagia land. But Digest is the dynamic imaging grade of swallowing toxicity, and this is out of MD Anderson, Dr. Kate Hutchinson. And this is a grading system of pharyngeal phase impairment specifically created for head and neck cancer patients. And you must familiarize yourself if you are working with this population. But it's exciting because it's being normed on populations outside of head and neck cancer because it's an excellent tool. It really is. And so it's great to speak a same language with other healthcare providers and a patient about how's their efficiency, how's their safety. And so Digest has been validated in both fluoroscopy and endoscopy. I'm going to go over the Digest on the next slide. So if you want to know more, sit tight. And a couple other things. The REST is up there. That's the robust esophageal screening test. And this is a screen that you can tag on to the end of your fluoro study. It adds a max 35 seconds onto your study with fluoro exposure. It tells you so much more information about what's going on in the esophagus. And so Dr. Watts and I had put out a paper about the feasibility of doing a REST protocol on outpatients at an ENT clinic, and it was at Mayo, and majority of patients were head and neck cancer. And there is a lot of esophageal pathology that we identified by looking in the esophagus. So it's always important to look at the whole swallow from lips to stomach. There's very important reasons. It's one ongoing swallowing continuum. Problems in one part can impact the other. And with head and neck cancer having high incidence of GERD, amongst other things, including just general esophageal pathology, it is always important to look at the esophagus and see the things that you gave them to swallow, where is it going? All right. Let's move on now to jaw. So the next is mouth opening, and we've already discussed the norms. So we purchased these measuring scales from Atos and Cranio Rehab. And if you don't have these scales, a quick method is the 3-finger test. It's 3 fingers vertically stacked between the teeth using the non-dominant hand, and 2 fingers or less meets the clinical cutoff for trismus, which is 35 millimeters. And then finally, lymphatics. Disruption of lymphatic flow from the tumor, resection, systemic treatment, and radiation can result in pathological accumulation of lymph fluid into surrounding interstitial tissues, which manifests as soft tissue swelling. And up to 90% of head and neck cancer patients may experience some degree of external head and neck lymphedema post-treatment. The majority have one external site, and the most common sites are the submental region and the neck. However, internal lymphedema is known to be much more prevalent and widespread. Up to 97% of patients may experience this and post-treatment, and most have at least 8 internal sites affected, most commonly the arytenoids, epiglottis, and the pharyngeal walls. So despite the high incidence rates, head and neck lymphedema is notoriously understudied, underrecognized, underdiagnosed, and undertreated. And when left untreated, as I mentioned before, the lymph retention activates inflammatory and immune responses. and it results in skin and subcutaneous soft tissue fibrosis and adipose deposition, and both of which further impairs lymphatic function. And I do want to add too that rates of fibrosis are greater and more severe in those treated with surgery first compared to radiation alone. So what's on the screen here is external lymphedema and fibrosis can be readily visualized and palpated and quantified by, for example, the MDA-CC head and neck lymphedema rating scale. You're using surface tape measurement composite protocols, so you can monitor change over time. Internal lymphedema requires imaging to be appreciated and quantified. So endoscopy and fluoroscopy are more accessible and less costly. And so we use the revised Patterson edema scale from Starmer. And also fluoroscopy, we'll talk about later on how TIMS MVP can help. Okay, moving on to rest. So I introduced this on the last slide, but in head and neck cancer patients, pharyngeal dysphagia severity and toxicity is captured best by this grading system, and it's based on both safety and efficiency grades. Safety grade is determined by the degree and frequency of airway invasion across liquids and foods, and the efficiency grade is determined by degree and frequency of retention across liquids and foods. Digest has adapted video swallow study ratings to the CTCAE nomenclature of ordinal toxicity use in oncology trials. So it goes from none, mild, moderate, severe, and profound, life-threatening. So 0 to 4. And it's an excellent way to track swallow function changes over time or changes from intervention, demonstrating improvement or deterioration of function. And I'll give you an example of this right at the end. A couple of things too, future published data will be documenting how digest is actually predictive. So for example, the odds of tube dependency at a grade 1 is doubled compared to grade 0, no toxicity, which is very helpful for identifying high-risk patients for upcoming cancer treatment. Okay, so these are the most used patient-reported outcome measures for head and neck cancer. We're not going to spend much time here other than to outline that they exist and are incredibly important to capture, and you may wish to consider further. So these capture perceived swallowing impairment. These capture reported oral intake. These capture symptom burden, speech and voice, and quality of life. All right, let's move on to treatment considerations for head and neck cancer patients. So we've got our systems here: breathing, speech, swallow, jaw, and lymphatics. We caffeinate. Okay. So for breathing, if you have a tracheostomy, you know, if your patient does, how would they fare or not? Is it not indicated because of a giant tumor with the passing mirror valve, or they needed it after surgery and you're going to work to get them decannulated? If they have a total laryngectomy, do they need a heat moisture exchanger disc with stomal housing? And then there's pulmonary clearance training. This is a critical aspect of intervention for head and neck cancer patients. As I said, many are chronic aspirators, and this is one part of minimizing an opportunistic infection, along with oral infection control, mobility, and immunity. So we can optimize pulmonary clearance or cough or throat clear strength to better expel or clear material that's aspirated. If they have a speech impairment from resection or radiation effects, such as a hypoglossal neuropathy, training the patient in compensations is important, like slow down, louder, open your mouth, pause between words, elongate vowels. But if they have velopharyngeal insufficiency, would a nose clip be helpful? Or a prosthetic like a palatal obturator or a lifting device? If they have a partial glossectomy, would a hard palatal lowering device be beneficial? So speech pathologists can work with prosthodontists in obtaining these specialized prosthetics that close off important valves or permit better contact of the tongue to the palate for bolus propulsion and speech. And if they are a total laryngectomy, what's their TEP situation, or do they need electrolarynx training? So for swallowing, speech pathologists, as you know, play a humongous role in rehab programs, which I'll touch on in a bit. Speech pathologists may determine the need for compensations, which should be viewed as a temporary crutch to help the patient get by from a safety standpoint in the short term, like a head turn for a hemilaryngectomy patient. But ideally, speech pathologists aim to rehabilitate the swallow by actually rebuilding impaired functions like strength, speed, and coordination of the swallowing mechanism. So McNeil Dysphagia Therapy Program is an excellent rehab platform for many head and neck cancer survivors post-treatment, not during treatment, post-treatment, to optimize function. And some patients need a medical or surgical procedure only when you're seeing them, like late effects, or done before behavioral intervention can begin. And so that's where you partner with your ENT or laryngologist, and that would involve a dilation, myotomy, where they cut the muscle, the cricopharyngeus, Botox, pharyngoplasty, so they can actually inject at the soft palate level to help close off the soft palate, or laryngoplasty, manipulating the vocal cord or injecting there to help with better airway protection or pulmonary clearance. And then we'll move on to jaw. So impaired jaw opening, as you know, is known as trismus, and the location of surgery or radiation significantly impacts the incidence. But trismus evolves most rapidly 1 to 9 months after treatment, but really 3 to 6 months is the biggest window. And it's worse for those who had premorbid jaw opening problems from the tumor or from surgery prior to radiation, which is why on a pathway, you're monitoring it from the get-go and be able to know and when to intervene earliest. Treatment for this requires both passive jaw stretching to increase mouth opening range of motion and active jaw stretching to improve rotary chewing, range of motion, and disuse atrophy. And then there's intraoral manual therapy. It can be very beneficial in manipulating the soft tissue fibrosis and lymphedema, so stretching can be maximized. And now let's get into lymphedema. So the gold standard intervention for head and neck lymphedema is known as complete decongestive therapy, and it's comprised of 4 components: manual lymphatic drainage, compression with bandaging or garments, exercises, and skincare. MLD is a gentle skin stretching technique that mobilizes lymphatic fluid to the nearest region of untreated or more efficiently working vessels or nodes. Patients receive formal therapy by a lymphedema specialist, and then they're trained on a home-based self-care program. And in head and neck, it's typically lifelong because it's a chronic condition, especially if they were radiated. But patient compliance with daily home-based manual lymphatic drainage programs has been found to be suboptimal and inferior to specialist-delivered services. And that's why they developed the development of advanced pneumatic compression devices to facilitate long-term compliance and are particularly helpful for those with self-limitations. So like MLD, advanced pneumatic compression delivers a gentle pressure of 40 millimeters of mercury to facilitate lymphatic drainage. And advanced pneumatic compression devices like the FlexiTouch Plus from Tactile Medical have been found to be safe, effective in reducing external head and neck lymphedema, associated functions, and pain, and is considered an efficacious part of a home self-care maintenance program. It also is reducing the lymphedema internally, which is one of my research interests. And so hopefully we'll be putting out a paper on that soon. Okay, this is the care pathway. So at Mayo Clinic, we use a clinical care pathway for head and neck cancer patients because it is the standard of care. Speech pathologists evaluate and optimize head and neck cancer patients before surgery, after surgery, before radiation, during radiation, and after radiation yearly till 5 years post. So let's first consider pre-surgery consultation. This is where you lay out who you are, why, and how you'll be working with the patient. And so we've got our baseline measures, right, of the systems on the right. They're important to obtain so that you know whether and when to intervene post-operatively. And once you know these, you will have a much more informed talk on expectations. So I always ask the patient, what's your understanding of what you're having done? Or what has the doctor told you about your surgery? Education on basic anatomy and physiology of these systems, particularly the ones that will be disrupted, is important. I show anatomy pictures and videos as necessary. Counseling is a critical piece so that the patient and family are better prepared, less frustrated, and feel more in control about their experience. So we discuss anticipated trends with that particular surgery, and we go through best and worst case scenarios. And studies show that preoperative counseling is associated with reduced length of stay and readmission rate, and it promotes safer, earlier patient readiness for hospital discharge. And I prepare them for post-op communication. So gestures, AAC, writing, smartphone applications like text-to-speech, very helpful. And then there's special considerations for laryngectomy patients. We do peer-to-peer visits where they meet with somebody who had a laryngectomy and be able to ask them questions that the healthcare provider would not necessarily be able to answer the best. And we orient them to supplies that they need for the rest of their life. And we complete the necessary paperwork for streamlined services as they transition home. Okay, let's move on now to post-surgical optimization. So post-op, it's important to compare new measures to baseline for all of your systems or whatever's impacted. Your patient will usually have more than one system involved. It is common to see mouth opening reduce after a surgery that does not involve the jaw per se in terms of surgery site. You will need surgical clearance before optimizing jaw opening in that patient. Some resections and reconstructions are so involved that trismus, honestly, will not be able to be truly addressed in an aggressive way until after radiation, and that's okay, but you've got tabs on it, right? And you're in communication with it about the team. Swallow optimization is critical. So at Mayo, I'm often removing the NG tube 11 to 14 days post-op following a FEES study. And that will guide me in my plan of care for the patient's home exercise program with PO intake. And following MDTP principles of exercise physiology is incredibly helpful and helps my patients gain function back while advancing their oral intake just in time for post-op radiation 6 weeks later. Reducing pulmonary infection risk is always a goal, and we should all be familiar with the pillars of aspiration pneumonia, as Dr. John Ashford likes to call it. Ongoing education and counseling is necessary, and we have special considerations for laryngectomy, like the success of the LEAK study, advancing the diet, pulmonary rehab, and activating their voice TE phonation. Okay, moving on. Pre-radiation evaluation. So who should we be seeing if your patient's just dropping in and it's no surgery, just radiation? Best practice dictates that all patients with cancers of the oral cavity, larynx, pharynx, or unknown primary with disposition to receive bilateral neck radiation are your candidates. Okay, so we've got just prior to radiation, speech pathologists update the patient's baseline measures if they were optimized after surgery, or if this is the new cancer diagnosis requiring definitive radiation, you're getting a new baseline of the systems, an actual baseline. Education is a giant piece to this, as you discuss prehab, the preventative programs that aim to thwart negative prognostic outcomes. Proactive care is efficacious and highly supported at high-level multidisciplinary cancer centers. The goal is to maintain strength, flexibility, and skill prior to and during cancer treatment, as opposed to reactive care, which occurs after cancer treatment when the damage has been done. Studies show this reduces anxiety, improves post-treatment compliance by involving the patient as a team member who can actually play an active role in their outcome, something that they can control, which is really how I phrase it to the patient. So at Mayo, we introduced the EAT staircase, eating all through radiation, which is straight from Dr. Kate Hutchison and her team from MD Anderson, and pharyngosize, which is Dr. Carnaby's. So regarding EAT, and I have a picture of the staircase right there, speech pathologists motivate patients to maintain intake of the densest, heaviest textures as tolerated, because we know that this causes greater muscle recruitment and movement trajectory. So we want them to stay towards the top of the staircase as they go through radiation. Patients with total oral intake during radiation are 2.3 times more likely to eat a regular diet long-term versus those who had limited to no intake. In those that need a G-tube during treatment, we aim to avoid prolonged NPO intervals, and because this is associated with better oral intake and quality of life measures 5 years later. So they're never going a day without putting something in their mouth. Regarding exercise, pharyngosize counteracts the loss of resistive bolus load during treatment encountered from the acute toxicities. So patients who comply had 3.6 times the odds of eating a regular diet long-term. They also have better post-radiation muscle mass on MRI of the floor of mouth and tongue, better swallow structure, range of motion, earlier diet recovery, faster PEG removal, and less hospitalization than those who did not exercise. We, of course, discuss oral infection control program, and we counsel extensively on what toxicities to expect during and after radiation, the importance of pain control, and communicating that pain with the radiation oncology team, and reiterating the importance of use it or lose it principles despite the toxicity. Now let's move on to rehab during radiation. So at Mayo, we see the patients every 2 weeks. We aim to optimize their PO intake and tolerance while helping to manage their toxicities. We check on their adherence to the prehab programs and the oral care programs. We troubleshoot any new safety or efficiency issues that arise with PO intake, and we provide ongoing education and counseling. We communicate with the team. We do not make it a habit of performing instrumental reassessments during radiation treatment. We clinically manage these patients because we know that the mouth and throat become quite inflamed and swollen, and we can predict what issues, if any, may arise, and if so, how to manage them based off of their pre-radiation swallow study function. And then finally, let's discuss post-radiation optimization. So as the toxicities subside, we guide patients in returning to items that they have been avoiding because of the pain and swelling. But for some, the patients need ongoing follow-up or intensive intervention to help them stay accountable to their goals. I want them coming into their 3-month post-radiation swallow study as optimized as possible. For some, this may mean going back to a regular diet with no supplemental shakes, stable weight. And for others, it's just weaning from the G-tube. And still for some others, it's just maintaining some daily oral consumption to prevent disuse atrophy. You will know their goals best because of the pathway that you're going to institute. Intensive therapy is indicated in patients who have delayed return to solid foods, have ongoing aspiration, have pneumonia during or after radiation, or are persistent tube feeding past 3 months. Ongoing education is a must, and ongoing team collaboration is a must. And here we provide a 5-year surveillance pathway. So as I said, the next reassessment after radiation ends is 3 months later, around the time of their PET CT scan. And the patient is seen again for a clinical and a video fluoroscopic reevaluation, and immediate intervention is enacted for any newly identified development of swallowing impairment, lymphedema, trismus, and of course, targeting pulmonary clearance too. Reevaluations are repeated at 1 year post, 2 years post, 3 years post, and 5 years post radiation, at which point they're discharged at survivorship with a maintenance plan in place. So let's go through an example of a care across the pathway. This is a real case, a real patient of mine who is really near and dear to my heart. So it's a 59-year-old male. He was diagnosed with the supraglottic cancer. It was an exophytic mass that extended from the right base of tongue to the right lateral wall and right epiglottic fold to the right arytenoid. He underwent a translaser microsurgery supraglottic laryngectomy with part of the tongue base resected, and then he went on to have adjuvant chemoradiation. So I saw this patient, preoperatively, told him what to expect. We knew what his swallow was. It was normal, despite the tumor burden. And then I saw him post-op. He had a significant swallowing impairment after the resection, as you can imagine. I'll show you on the next slide what that looked like. But it's a digest 4, so his safety was profoundly impaired. Gross aspiration, more than 25% of the bolus per digest, and his efficiency was severely impaired. And so he needed to transition to a G-tube so that he could survive now and survive during radiation. So I optimized all those systems along the way. Then for radiation, he had his counseling on pharyngosize and EAT. We completed another swallow study, and did that rehabilitation that I had provided, we did improve him up. We bumped him up 1 level each. So he's considered severe safety, and moderate efficiency. And then during radiation, saw him every 2 weeks, did all of our preventative programs, oral infection control. He kept up the adherence to the programs. And then post-radiation, believe it or not, this man did amazing. 3 months post-radiation, he came out to a digest 1, which was just a mild impairment in safety. His efficiency was normal. It was incredible. So let's look at at the swallow study now. Of course, we were able to get him off of his G tube, and he was happy as a clam. So here is the patient 15 days post-op. So there's a giant defect of all the structures that were removed with gross aspiration of that bolus. Very poor tolerance to the aspiration, very upset. You know, he did make a point to mention to me that he just did not know if he wanted to live like this. And this was right before radiation. You know, head and neck cancer patients have like a 17 times higher rate of suicide than any other cancer patient. We were able to be positive and keep him on the up and up. So here he is 3 months after radiation. That's incredible. I mean, visually, it doesn't even look like he had a resection. But we were able to engage all the good parts of his swallow and make up for it and kept it active. What we did see, and you can see it in the upper right-hand corner, that he did develop, of course, the natural lymphedema that you would get from radiation. So our next step was to start intervention for the lymphedema. So that's that case. Okay, so we've got 7 minutes, so we can leave 10 minutes for questions. I'm going to just show you a couple little tips and tricks on how to use TIMS especially for your head and neck cancer patients. And we're going to go quickly. There are website tutorials, so this is not a tutorial. I'm just bringing to your attention what you can do. So when you first open the study in TIMS review, you hit the green unlock button in the right upper hand corner, and you double click on your scout to begin analysis, right? So the scorecard button is along the upper horizontal bar, and you can select digest fees, voice, MBS IMP, PAS, and coming soon, the rest, robust esophageal screening test. That's really exciting. So the scorecards, this permits the rating of penetration aspiration score and percentage residue after the initial swallow for all the trials that you give. And so it allows you to do that for digest, and then ultimately you can get your safety and efficiency grade and the overall grade. And it automatically calculates it for you, and then it's transferable to your report. So just be aware that digest scorecard is in there for you, and it's fantastic. Then measuring bolus efficiency for digest. So if you have difficulty guesstimating visually what the percentage is left behind after the first swallow for your efficiency rating, you can use the magic brush, which I have the image up there. That's what the magic brush looks like. And it will allow you to highlight the bolus in their mouth right before they go to swallow. And then you can highlight what is left, and you would put in, you hit the ruler, which is right here, and it will automatically calculate the percentage that was left behind. You can label your bolus. It's great. And then the next thing I wanted to show you, well, actually, sorry, you would change I forgot to mention, change the pixels that you see loaded from, 17, 815, you would change that to 100, and then that will automatically calculate the percentage left behind. Again, the tutorial is on the website. And then I want to bring your attention. So, as I mentioned earlier, fluoro is an excellent tool for being able to see external and internal lymphedema develop after treatment, and then it diminish after intervention for that lymphedema. And so you would want to use the linear tool here. You can see this. So here's someone's before radiation, 3 months later, they have big development of external and internal lymphedema. And then I treated them with FlexiTouch, and their internal has reduced, their external has reduced, and it's great. You can see it, but it would be great to measure it, right? So that's where you could bring in the linear measurements and use the linear tool, which is on the sidebar. And I think using the thinner line is best for purposes of what we're looking at. And so it's important to, in order to compare, sometimes patients are positioned a little differently in the different distance within the fluoro machine, or 2 different fluoro machines are used, in which case it would be kind of like not the best comparison. You want there to be precise, something that you can actually say this is a stable measurement. And so using the C2 to C4 scaler, you want the same pixels from C2 to C4 on all these, and then you know that you can say these are solid measurements. Another scaler that's commonly used is the penny taped beneath the chin. Okay, before we, oh yeah, and then you can use the ruler and it would measure all these for you, and you can save them and label them. This is the most important part. So at the end of my presentation slide deck, you're going to see a whole bunch of references. And so I talk about eat and exercise, and there's a great course on this, and the papers that support these, the EAT staircase, digest and digest fees. Dr. Kate Hutchison is actually doing a recording webinar where you can learn more about digest. And then we got MDTP, of course. You can go to that website for more information on certification and all the research that supports that. EMST, of course, the website for ordering that tool for your patients. Pharyngo size, there is a self-paced CE course for it at that website. MASA and MASA-C, more information there. The revised Patterson edema scale from Heather Starmer and an associated link for more information. The MDA-CC head and neck lymphedema rating scale for external lymphedema, the robust esophageal screening test, and the website for more information to get trained. And then some great resources for laryngectomy, tracheostomy, trismus, lymphedema, manual therapy, and I have a link to the NCCN survivorship guidelines. So that's the end of my presentation. Thank you so much.
Thank you, Jessica. Just a quick announcement for those who are here with us live. Unfortunately, we have realized that Zoom is having major technical issues. And so if you have friends and colleagues that have been attempting to log on this whole time and have been unable to, please let them know that Jessica and I will work to host another live event, but this will be put up on our website here within an hour. So if you have people reaching out to you, please let them know. But with that, we're going to go ahead and jump into Q&A. So the first question is, for the patient case study, supraglottic cancer you shared, what diet was the patient on when he was undergoing treatment?
So he had his G-tube, that was his primary mode, but it was water, a lot of water. He was able to drink some other thin liquids, and we were doing puree as a workout.
Awesome. The next question is, do you clear the use of EMST with your physicians before use?
No, not routinely. Not routinely. If there was a particular complicated resection and reconstruction that made me give pause about being able to use it, that it would somehow be hurting the patient, I would, but I can't even think of a situation that I needed to get clearance. It was more about this patient, has such a defect, can't get the lips around it, is not a candidate to be able to use it.
Awesome. The next question is, with late radiation effects, are there any exercises or treatments you typically use beyond referring for dilation, myotomy, etc.?
For late radiation?
Yes.
Sorry. Are there any exercises?
Yeah, so she said, with late radiation effects, are there any exercises or treatments you typically use beyond referring for dilation or myotomy?
Well, whatever they're swallowing at that time, or what I think they can swallow, we want them to, even if they aspirate, we want them to be able to keep using their swallow to prevent further stiffening. And so you're using it or losing it. So if, generally in head and neck cancer patients, especially late effects, thinner is better. Thinner is a lot easier than thicker, and that includes food. So if, a lot of times if we can get them drinking thin liquids, but it's using a swallow, immediate throat clear or immediate re-swallow with each sip to help expel some of that aspiration, get them on EMST 150, that's great. We want to be able to work swallow speed and some sort of swallow strength with something a little denser. It just depends on what their situation is. What are their goals, and is it realistic? And, are they already losing weight, and what, are they already getting lung infections? I mean, these are the real problems that you deal with late effects patients. And so it's not handing them a list of traditional swallowing exercises. Your goals are get them swallowing something. is that meeting what they're also looking for too? Some of them don't want a feeding tube, and that's okay. You just manage them until, they're going to reach a point where they will need enteric support. And so that's really where your focus is turning on, is nutrition and efficiency and safety and those related sequelae.
Question is, are you doing both video fluoroscopy and fees at pre-treatment evaluations and follow-up checkpoints? Also, what is your timeline for post-treatment instrumentals? So, for example, do you wait 3 months for all patients after radiation therapy and 2 weeks for surgical?
Yeah, so we use fluoro across the swallow continuum of care, always fluoro. We also use fees though, but we're not using fees always when we use the fluoro. So it just, the patient dictates the needs for fees. So in my institution, the patient is routinely getting scoped by ENT and radiation oncology at their surveillance visits anyway. So I have access to all their scopes. I know then what their internal structures look like. And I already know what their swallow looks like with fluoro. So I'm not needing to fees these people on a routine basis. I get all my information from those scopes, and there's nothing that the fluoro couldn't tell me unless there's a particular surgery involving the larynx, in which case I enjoy using fees then to really look at the laryngeal integrity, because that's something that fluoro isn't able to give me as well. And so we're not using fees at all of these benchmarks. We're using fluoro, but we use fees for our post-op NG tube removal to get them started, and then their particular surgical case dictates what I would do with fees in the future.
The next question is, does additional radiation exposure from multiple video fluoroscopy to assess swallowing contribute to worsening radiation fibrosis?
Good question, and no. The speech pathologist has to do 33,000 studies a year in order to potentially have skin damage. According to our safety regulations for patient care, a patient can have up to 1 swallow study a month and still not meet the cutoff of what would be putting them in danger. And so we have to, you have to kind of get yourself educated on what is radiation exposure for a swallow study. It's quite minimal. We order in the ENT department hundreds of CT scans a week, and nobody gives a thought about the radiation exposure for a CT scan, which is tremendous and much more than a swallow study.
This question is about pharyngo size. Do you ever use pharyngo size beyond the prehab/during radiation phases?
No, it's meant for radiation.
And Jessica did have some courses in her resource slide, but this question is specifically about lymphedema. The question is, can you suggest continuing education regarding lymphedema for this patient population?
Yeah, there's a lot of hands-on manual lymphatic training courses. There's an Academy of Lymphatic Studies, Norton and Close, and that's Close with a K. They all teach, and Brooke's taken some of these courses. They're all various and different, but that would be a good starting point, is checking out one of those.
Would you have a rough estimate of how many of your late rads end up electing a functional total laryngectomy? We've started to see it more in our practice.
A lot, yeah. I mean, in some cases, it gets very bad. They turn frozen, and a lot of improved quality of life is seen from electing a TL functional TL, definitely. I don't have a number, but it's important.
Emily had a follow-up question about radiation exposure, follow-up about radiation exposure from video fluoroscopy. Do you have any studies or resources to support this education and advocacy? I will say on the TIMS website under advocacy, in the MBS section, we have a lot of literature about MBS, specifically including radiation exposure. But Jessica, I don't know if you have anything else specific.
We cover that extensively in our course for REST. Yeah, we've got an arsenal of literature, definitely.
The next question is, which is the effective exercise for pharyngeal phase post-radiotherapy induced fibrosis?
Effective exercise?
What is the most effective exercise? I feel like that's a
Oh,
loaded question.
sure. Well, I mean, so the best exercise for swallowing is swallowing and engaging the entire whole system and not just part of the system. And so there's not an exercise that's the best. It's them swallowing a bolus. It's like lifting weights at the gym.
Awesome. This question is specifically about TIMS. If we have TIMS, do we all have access to the scorecards? Yes. So if you have TIMS and you're on, you have TIMS MVP, you have access to all of the scorecards. So I'll put a plug in for MBS IMP, Digest, and the rest will be in there probably within the month. So you will have access to all of those, including the rest, as soon as you update your TIMS. And then the feature that Jessica showed with analyzing the bolus and anatomical changes, you have access to that as well. The next question is, do you ever run into patients who have financial constraints and refuse the studies, or MDs who do not order them as willingly due to the cost?
So we order them ourselves. If a doctor consults speech pathology, we order our own swallow studies, but it's also, they also can be ordered by the ordering physician too. I mean, that's what prompts the patient referral initially. Before surgery, the surgeon's ordering a pre-operative swallow study and that clinical consultation, so I can measure their mouth opening and talk about what to expect and all that. So those doctors can order it, and then also once they're in my hands, then I'm placing the order for the 3-month swallow study when I'm done seeing them at the end of radiation. So I'm handling those consults myself.
Awesome. Thanks, Jessica. And just in wrapping up, just a quick reminder that we do need you to complete the survey by tomorrow at 5:00 p.m. Eastern time, and then we'll go ahead and get everyone registered for their ASHA CEUs if they're choosing to do so. There were a lot of questions in the chat about Jessica's slides. This replay will be up on the website, so you can go back and rewatch and take screenshots, and we can include the resource page that Jessica included in her slides also in a follow-up email, so that you all have the clickable links to the resources that she provided in her presentation. So we just want to say thank you to Jessica for sharing her time and expertise today. And again, we thank you all for joining us this morning. Jessica, do you have anything else you want to close with?
No, just thank you again to Brooke and TIMS University for having me be the inaugural presenter. It's very exciting, and it's an honor and a privilege. Thank you very much.
Awesome. Thank you all. We will see you later.
Bye.